Okay, so I'm going to demonstrate how to take shoulder views. All of the cassette sizes are going to be 10 by 12. SID is going to be 40 inches, and you should be able to see for the shoulder views, you should be able to see the lateral 2/3 of the clavicle, the glenohumeral joint, the upper scapula, and the proximal humerus. And these are the chronic pain or non-trauma views that you would do. So for A to P shoulder, external rotation, I would have the patient be standing in the center, but we're going to make sure that the central ray is going through the coracoid process. So they're going to be going through it's going to be going through the coracoid process. We're going to ask them to supinate their forearm, and we're going to make sure that the arm is a little bit abducted as well. They can also turn their head to the opposite direction, just so we can get only what we need in the film. We might need to use a sponge to angle the position to keep the arm immobilized. Otherwise, if they can stay still, then you should be good. Like I said, the central ray is going to go through the coracoid process perpendicular to the center of the film, and that is it for the AAP shoulder external rotation. The internal rotation is you can leave the patient basically where they already are, but you're going to have them internally rotate their arm this time, and they can actually rest their hand on their leg. But the film is going to be placed either in the bucky if it's greater than 10 centimeters, or it can hang on the cassette holder. If the injury is proximal, then we want the upper border of the film to be 1.5 inches above the head of the humerus, and then if it is distal, we want it to be 1.5 inches below. We want a line through the epicondyles to be perpendicular to the film plane, and we again can have them turn their head away. Central ray is still perpendicular to the coracoid process, and you can see that lesser tuberosity near the glenoid fossa, and the greater tuberosity on the lateral side for this view. So that's internal rotation. For baby arm or abduction, patient can still stay standing up where they are, but they're going to raise their arm this time, and their hand, is facing forward, their palm. Central rays still through the coracoid process, so you can see the shoulder joint and the AC joint for that view. And that's it for those chronic views. So if the patient has trauma, then we would take some different views. So basically we would take an AP neutral rotation view. So patient would still be, hopefully, if they can stand up, and we're still going to center the central ray to the coracoid process, but we're just going to have them rest their palm against their thigh like this, and then the epicondyles will make a 45-degree angle to the plane of the film if they can rest their palm there. And that's for neutral rotation. Then for the Grashey view, we're just going to have the patient be A to P, but we're going to turn their body 30 degrees. So you can still see the lateral glenohumeral joint. You'll just want the patient's body, like scapula, to be use that as a reference point to set them up for the 30-degree angle. And that's it for the Grashey view. But the scapula Y for the shoulder is actually going to be P to A with a 60-degree body rotation. So they're going to be facing, they can be standing or sitting, but they're going to be facing the upright detector. So their front of their shoulder is touching the upright detector. And the hand, if they're here, that's fine, because it's going to depend on how they're presenting and when they come in. But the scapula should be at the end of the upright detector, so you can palpate it. So it's hard to show you, and there's not an actual machine in here, but you would be able to see if there was any dislocations or scapula fractures there, because you can see the coracoid still and the acromion process in that view. So that's it for the trauma views. You're still using a 10x12 cassette, and you're still at 40 SID for that. Of course, we would always want artifacts to be removed, and any jewelry, necklaces, or anything like that, and then we would instruct the patient to not move or breathe during any of these views. Okay, so now we're gonna go to the 2 clavicle views. So there's A to P clavicle. I'm just gonna show you sitting since it's easier. I guess technically your patient could be sitting as well. But so you're going to have them, or you're going to center the central ray to the center of their clavicle. So then you can center the film, and you can have them look away if you need to. It's perpendicular. Central ray is perpendicular to the plane, like always. And you're going to be able to see the A to P projection of the clavicle. The cassette for the clavicle views are 10x12 landscape. And then for the A to P semi-axial, the patient is standing up, and they're still in A to P position. But the only difference is the central ray is at the center of the clavicle, but there's an angle between 15 and 20 degrees. Cephalid. So that's the only thing. So there is an angle, there is a tube angle with that. You should still be able to see the clavicle, and this would allow the ribs to be out of the way, as well as the scapula to get out of the way for that. Okay, now I'm going to go over AC joint views. So there's unilateral and bilateral views that you take. So for unilateral views, you are using a 12x10 cassette, and you are taking individual views of the AC joints, okay? So for that, you're going to have the patient in an erect position. They'd be standing up like this in the center of the bucky. Back is against the bucky. You're going to center one of the AC joints in the center of the film. So you probably over a little bit. Just leave the arms hanging by their sides. And this one, on the first exposure, there's no weights. Your patient is not holding any weights. And on the second exposure, you're going to do the exact same thing, except your patient is going to be holding 2 equal weights on each wrist or with each hand. The central ray, like I said, is perpendicular to the body at the level of the AC joints at 40 inches SID. And this is just going to show each AC joint to compare, and you'll be able to see any dislocation or separation, but you want to make sure your collimation is only exposing what you need. So then if you are going to take bilateral views, you're going to use a 14 by 17 single cassette for that, and you're going to use 72 SID for that. Same, your patient is still going to be with their back against the bucky, standing up or seated, and they're centered in the middle of it. So the central ray is perpendicular to the midline of the body, but make sure it's at the level of the AC joints. And so you're going to be able to see both joints, so you can compare them in that way for the same thing as you would. And you are also going to take 2 different views, one with weights and one without weights, is just like you did with the unilateral views. Making sure there's no artifacts in the way, necklaces or anything like that. And that is it for those views for this week. Thank you.